evening. Welcome to yet another edition of the IDEC Cafe. We are so happy to be back again after a small hiatus. And as all of you know, IDEC started 10 years ago. It started as a forum of excellence. And in the last few years, we started with the IDEC Cafe with an intention of bringing world class national and international speakers to our forum. So we have some very exciting lectures for you, and IDEC Cafe will now continue every month as usual. And I'm so happy that we have restarted this. So now I'm going to hand over the proceedings to Sanjay for the wonderful lectures that we have ahead of us. Sanjay.
Thank you, Neha. Good evening, everybody, and it's a warm welcome to all of you to this evening edition of IDEC Cafe. We've had great responses in the past about IDEC Cafe, and we've had people from, various parts of the globe which have logged in, and they have, listened to these lectures keenly, interacted, sent their questions, and we have always been very privileged and honored to have all of you with us. I have with me on in the platform Dr. Guillermo Umpiras, who is the chairman of IDEC, along with Nita. And today we have two excellent speakers. I think they are luminaries in their own right, legends, I would say, who have done incredible amount of work that they're going to speak today all about it. Uh, I have with me Dr. Samit Ghosal, and shortly he will be starting his lecture. But I must say that, this science which we bring to you with a lot of interaction, we feel that we fulfill what we really started out IDEC for. It was a journey, and over a period of time, we have been known for a high scientific quality content that we bring to you. So today is just another edition that we're going to bring, and we hope you enjoy it. But at the end of the two lectures, we hope you send us a lot of questions, which I'm sure the two speakers will be very happy to answer for you. Let me start without wasting any time to introduce our first speaker, Dr. Samit Ghoshal. And for all who have heard him, he's a wonderful speaker. He gives excellent lectures full of analytics and his own perception about the topic. And with a lot of research background that he has, he brings the lecture to you with a lot of interest. And I'm sure you'll find it very with a lot of take-home points that you can take back and see how you can utilize them in your day-to-day practice. But Samit, he sent me the slide with all modesty, hiding all the achievements that he's done in his entire career. But he's a chairman of Nightingale Group of Industries. He's a secretary of the East Calcutta Doctors Group. He's a life member of RSSD and IDF. Can I have the next slide, please? And Samit has been practicing internal medicine with a special interest in diabetes for the last 24 years. He completed his MBBS from Calcutta National Medical College and his MD from Sri Ramchandra Medical College and Research Institute, Chennai. He gained additional training in diabetes from Cardiff University, UK, where he was granted a diploma with distinction in diabetes. And to broaden his expertise, he completed a diploma in endocrinology from Glamorgan University, UK. With a special interest in research and statistics, he completed his master's in diabetes care with a focus on medical statistics from Glamorgan University, UK. He was awarded the best poster at the Berlin Faculty Forum from the Kuvadis study on diabetic neuropathy. It's a privilege and honor to have him with us, and I would like to hand over the proceedings to him for his lecture on cardiovascular risk assessment in patients with diabetes. I'm also joined with my other team members from IDEC, Shilpa Joshi, and the others will follow shortly. So over to you, Samit, please.
Thank you. Thank you very much, Sanjay. Thank you very much, Nita, for inviting me once again. I really had a wonderful privilege of participating in this probably a year back, and it was wonderful. So, and whenever I am invited from your end, because of the quality of the program, I spend probably 2 extra days on the slides. So let me just share my window. So my slides are visible?
Yes, they are. They are.
Thank
Go
you.
ahead.
Thank you. So I think I'm the opening speaker, and the topic that I've been given was to take a holistic view of the cardiovascular risk assessment in patients with type 2 diabetes. And I deliberately, wrote this subcaption below it, which is beyond LDL and blood pressure, because traditionally we have always been taught that qualitatively look at the cardiovascular risk factors. Blood sugar or type 2 diabetes itself is a cardiovascular risk factor, and then the additional risk factors, which are LDL cholesterol and blood pressure. But I'll be a little bit of the presentation will be a little bit thought provoking. I'll be looking into certain deeper nuances of cardiovascular risk assessment. How accurate are we? How population based are we? How individual or precision based are we? Just a couple of slides on epidemiology of cardiovascular risk. I remember when we were in medical school, it was very common to say that type 2 diabetes is a cardiovascular risk equivalent. It's like every single type 2 diabetic is equivalent to someone having a heart attack or stroke. I remember the famous dialogue given to us by our teachers, which is the ticking clock hypothesis of Stephen Hafner. It's just a ticking clock which is happening. And we did not have interventions back then to retard the progression of cardiovascular risk, except for ACE inhibitors. Not even the ARB data or even the statin data were at best modest. But of late, we know that it's not true. It's not true that all type 2 diabetic patients are equivalent to having a cardiovascular disease. Although near about 50 to 60% of all-cause mortality in type 2 diabetes is driven by cardiovascular disease. Now, this is the global data. We did an analysis called the MARC analysis a few years back in the pre-COVID times from all over India, and we found that in India, the ASCVD onset in type 2 diabetic patients is probably 5 to 10 years earlier in a much, much younger age group. And this is the MARC study, which we found that, which was done on asymptomatic type 2 diabetic patients. Their CV risk was assessed using QRIS-3. Obviously, nowadays, we also have QRIS-4 to bank on, but we use QRIS-3. And we found that over 50% of the asymptomatic males aged 45 to 54 are already at a high Q risk, ASCVD risk. So the Q risk score was more than 20%. If you look here, the male versus female comparison, you see that the 20% risk is eclipsed at 45 to 54 years of age in males and above 55 years in case of the female. Now, there were 5.7-fold higher relative risk in younger patients compared to the healthy control. So we are seeing that in the Indian subpopulation, probably because of increased insulin resistance, we find that the ASCVD profile or its progression starts much earlier, at least a decade earlier than our Western counterpart. Now, having understood the risk profile, that we have an increased cardiovascular risk in type 2 diabetes, we broadly classify them into two different cohorts. One, the primary risk based on intervention, based on reduction of the risk. So we say the primary CV risk reduction cohort, and another is the secondary. Now, the secondary part, I think, is quite easy to understand. You have type 2 diabetes, and you have an established atherosclerotic cardiovascular disease or other target organ damage, which leads to cardiovascular mortality, which, example, CKD, or you may have MASLD now, as we say. This is the easier part, when you already have the established disease and you need to implement extensive and much more aggressive therapy for this subset of patients. But the primary prevention cohort is a very heterogeneous group of population. It's a huge population and a very heterogeneous group of population. Now, how do we assess their cardiovascular risk? So, for example, a type 2 diabetic patient who have not yet developed an established cardiovascular disease, but has cardiovascular risk. Now, traditionally, if you go back to the older ADA guidelines, they used to tell us, enumerate those risks. So if you have type 2 diabetes, more than equal to one cardiovascular risk factor, say a dyslipidemia, say hypertension, or a bad family history, well, you have a high cardiovascular risk. Or if you want to objectively look at it, quantify it, not qualitatively, but quantitatively assess it, then there are risk scores which can be used. So these are the two aspects that I will be spending some time on. I will be dealing with the third part, which is exclusively, questioning this qualitative way of assessing cardiovascular risk. I have termed this particular subheading as the illusion of an independent metric. What do I mean by that? I will take you through 4 patient profiles. So this is patient A, and this is patient B. And we will look at them. Both are 55 years of age, having a type 2 diabetes in the backdrop. I will be having a look at the CV profile from the systolic blood pressure profile. So patient A has a systolic blood pressure of 150. Patient B has a systolic blood pressure of 180. Now, remember, when in a qualitative way of assessing them, we were saying if you have type 2 diabetes plus one additional risk factor, which is hypertension, the patient has high cardiovascular risk. Now, does patient A has the same cardiovascular risk as patient B? The blood pressure of patient B is in the stage of hypertensive urgency. There is an urgency in treating it because there is an imminent target organ damage that we're looking at. Whereas patient A, we can go slow and we can modify the risk factor by reducing the blood pressure to below 130 in a gradual manner. We don't have a hurry. And they both of them have a different cardiovascular risk profile. The same thing goes for cholesterol. Now, patient C, 35 years of age, LDL cholesterol is 120. Patient D, 50 years of age, LDL cholesterol of 180. Now, do they have the same cardiovascular risk profile? We have been taught by this qualitative way of assessing them as if there is a linear risk profile. So anyone with a diabetes has dyslipidemia, there is an LDL more than 70, there is a linear risk profile, which is not true. Someone having an LDL above 180 is probably a potential candidate for a familial hypercholesteremia. We need to immediately address this patient's risk profile and start a high intensity statin. Whereas those who are younger, having an LDL cholesterol of 120, we gradually start their therapy. We still have some time in slowly bringing down their plaque burden. What about someone who has an LDL cholesterol of 70? Now, it is said that our target is treating our patients with the statin if the LDL crosses 70 and has a high cardiovascular risk. But my patient has 70 already, but has a different profile which increases their atherogenic remnant particle number. So the triglyceride is high, the lipoprotein A is more than 30, or maybe the apolipoprotein is more. So in spite of 70, this patient has a high cardiovascular risk, which is called the remnant risk. So you see this three patient profile have three different types of LDL cholesterol, has three different types of risk profile. The two patients with blood pressure had two different types of blood pressure, systolic blood pressure, and hence different types of cardiovascular risk profile. This individualization is completely missing when we are assessing a patient qualitatively. Quantitatively, when we do so, also we should be mindful that when we say our patient's LDL cholesterol is normal, we have achieved a low cardiovascular risk profile. That's not true. When you have risk A plus you have risk B, so hypertension, dyslipidemia, we cannot add those two risks and say this is the total risk of a patient. It is not a linear metric. What happens is, in spite of addressing LDL cholesterol targets, in spite of achieving the HbA1c target, in spite of targeting the systolic blood pressure target, each of the variables have an independent, unmet, or additional risk factor, which cumulatively gives us a huge cumulative CV event risk. This is what we need to tackle. This is what we need to assess. Instead of going just by those metrics, because if we just go by the metrics, this cumulative cardiovascular risk will be completely ignored and we will be suddenly faced with an event down the line. Type 2 diabetes acts as a catalyst for this. It's a compounding factor. In the presence of type 2 diabetes, whenever dyslipidemia and atherogenic dyslipidemia comes in, systolic blood pressure starts going up, MASLD comes into the picture, it has a multiplying effect and the damage starts increasing exponentially. Now, if the qualitative way of assessing this cardiovascular risk factors, or if these independent LDL and systolic blood pressure targets are not enough, does cardiovascular risk scores help us objectively? It brings in a number. So it is a number which is inclusive of dyslipidemia, inclusive of systolic blood pressure, inclusive of MASLD. Is it more holistic? Now, we have a number of scores which assesses cardiovascular risk. Ones that incorporate type 2 diabetes and diverse ethnicities are score 2 and QRIS 3. Of that, QRIS 3 is a little bit more heterogeneous. It incorporates type 2 diabetes duration. The Asian, Indian ethnicities are also captured in it. It's probably a little bit more applicable on a global basis than the other risk scores. Now, as I was talking about, this risk score does not only include your type 2 diabetes and duration. It also includes systolic blood pressure, includes HDL cholesterol, total cholesterol HDL ratio, erectile dysfunction as independent cardiovascular risk factor, ethnicity, rheumatoid arthritis, mental illness, use of antipsychotics, corticosteroid use, etc., etc. So it looks like more holistic. Problem is, there are 22 variables that we need to assess in order to get the cardiovascular risk assessment done with this engine. Imagine in a busy clinic, sitting down and using 22 parameters to find that risk. This is exactly the reason why most of the risk scores remain a risk score and have been rarely used in clinical practice. But what we did 4 or 5 years back did a follow-up of the MARC trial, because we collected all those data from all over India, where we used QRIS3, we used machine learning algorithm and did a dimension reduction, and we identified 10 very simple parameters which we normally capture in clinical practice, which also feature in the QRIS3 scores: age, sex, BMI, smoking status, systolic blood pressure treatment, angina, total cholesterol, cholesterol HDL ratio, chronic kidney disease. And we found, based on this, when we created the mobile app, if you just click on those parameters and you say, what is the risk profile, you get a color coding and you get the high risk individuals. Obviously, if you have more time, if you get the high risk individuals screened, you can do the full 22 Q risk assessment and get a confirmation of the risk status. This model that we created, we found it had a 94.4% predictive accuracy with that of the full 22 variable QRIS3 parameters. However, this also does not take into account the cumulative, the risk which is accumulating over the years. This assessment is also done at a point in time. And hence, all the years that the patient passed through, the last 10 years, 15 years, with uncontrolled diabetes, uncontrolled hypertension, uncontrolled dyslipidemia are not reflected. We need a more integrative approach. Now, risk profile can easily be assessed on an individual patient. The minute the intervention comes in, these patients have never been part of the trial. The intervention comes from cardiovascular outcome trial done in another group of patients. Maybe my patient has some features similar to the groups who have included in these trials. But wouldn't it be wonderful if my patient and the patient's profile, the patient's clinical and lab parameters could have been integrated in some way to the ones which were done in CVOT, incorporating the risk factors as a cardiovascular risk factor of the patient, and then choose which drug we want to use by calculating the patient's own absolute risk reduction in ARR. So we again did this very recently, just published in 2025, which is the net benefit equation. We are no longer extrapolating the CVOT data and putting it on our patients. We are taking our patients' data, our patients' risk profile, incorporating them into the cardiovascular outcomes data, and taking out the patient's NNT. What is the NNT? What is the absolute risk reduction from the MACE point of view, from the heart failure point of view, from the CKD point of view, and then deciding what should be the appropriate therapy. So this was the initial, all the CVOTs, 17 CVOTs, or more than 132 patients who were whose data was taken into consideration. Based on that, we created this net benefit profile. So you see what happens to the patient's absolute risk reduction by incorporating the patient's data into the CVOT data, and also look at what the side effects are there, what side effects came out from by putting a patient on SGLT2 or on GLP-1 receptor agonist. So that is also a risk profile. Just like we're estimating cardiovascular risk profile, the treatment-related adverse events are also taken into consideration in this particular window. So what we have created again is a type of a mobile app, a very simple app, where you estimate the patient's MACE risk or ASCVD risk. And here you just put the number. It's a slider. So as you slide, you will see the number here. So whatever is the patient number, put the slider there. Heart failure risk, you estimate. You can do a TIMI, Hadassah, you can do other risk scores, and you put it here. And then do a CKD estimation risk and put it here. Once you have all the sliders in place, then you get a policy curve, and the individual patient's NNT will be calculated. The absolute risk reduction with an SGLT2 versus a GLP or a combination, as far as MACE is concerned, heart failure is concerned, or renal risk concerned, will be given to you in this particular. And even we have a box here which you click, it will also tell you which exactly is the therapy that you can choose from. So this is the patient phenotype based decision making, incorporating the cardiovascular risk into the decision making of the choice of agents. So we can use, if you find the NNT is tilting towards a predominant ASCVD risk profile, choose a GLP-1. It is tilting more or less towards the heart failure and CKD, choose SGLT2. Or if you're getting a mixed phenotype, you can use a combination therapy. Now, having done so, all the estimation that we are doing are at that point in time. Again, I'm saying a cumulative estimation of the risk is still missing. A large section of patient may have a borderline LDL cholesterol, may have a borderline systolic blood pressure, and may have a borderline intermediate risk score when we put them on the Q risk estimation. What do we do with them if they're a younger population? The recent AHA, the recent ADA and ESC guidelines says that these indeterminate patients, borderline patients, are the ones in whom we can do a CAC scoring, coronary artery calcium scoring, to clinch the diagnosis whether we should put them on intensive statin therapy or not. So what is the future? The future of CV risk estimation is summarized in this particular slide. It is called the precision cardiology. This is a new frontier. We need certain biomarkers to complement the existing ones that we have. For example, LDL needs to be complemented with ApoB or little lipoprotein A. We are already seeing that the ADA is trying to bring in a few of those markers into routine clinical practice. We need to see the lifetime exposure of cholesterol years, which is going to tell us about the progression of the plaque burden instead of assessing our patients' cardiovascular risk at a point in time with a single LDL cholesterol value, with a single triglyceride value. And then a little bit more individualized data-driven prediction will be the polygenic risk scores, where individual SNPs will be assessed. Each of them are going to impart a small risk, but when you bring in all the SNPs together, you have a polygenic risk scores. And then when you put the polygenic risk scores in the AI and digital twin simulation, the twin simulation will take all this data in and will simulate the patient if they are put on a SGLT2, a GLP, an ARB, or a PCSK9, and will tell you the results. So having the results in hand, then you choose which patient, which therapy is to be implemented for which patient. This is absolute precision that we're looking at. Probably the last two slides of mine, probably what we are looking at is this 10 years risk score getting supplanted in the near future with a lifetime cholesterol years risk profile. Because if you look at the way we are now going ahead with the risk estimation, we are following this upper line, where by the time we are putting in standard of care, it's too late. It's already a significant amount of plaque burden which is there, and that is our starting point. If we look at the cholesterol, years of accumulation, just like we do with smoking, just as we do with HbA1c, we probably will be able to flatten this plaque burden curve in the near future. To conclude, we are doing, if you already have patients with the ASCVD, which is established, this is the secondary prevention profile. The risk profile here is clear cut. You know what to do. LDL less than 55, stringent lifestyle modification, smoking cessation, etc., etc. If not, we are in the secondary CV risk profile. Better to do it quantitatively a little bit more. If we do it qualitatively, we have to bring in the other biomarkers also. Or we can do it on a phenotype based, not only remain focused on ASCVD, but looking at other avenues through which cardiovascular risk increases through heart failure, CKD, MSLD, etc., etc. ADA has now included NT-proBNP as an annual routine test for all type 2 diabetic patients so that we do not fail or do not miss the stage B heart failure. So for its early detection, this biomarker has already made its way. There is a huge investigation going on lipoprotein A. It's still not a therapeutic target, but for a risk profiling, it is already now in a lot of guidelines. If you have the LDL under control, if the lipoprotein A is high, you need to intensify your statin therapy or maybe add an ezetimibe or a bempedoic acid. So to end, the one more area which is an evolving area is calcium artery scoring, as I told you. AH and ESC are already utilized them as a risk modifier. ADA is a bit skeptical here. They're saying it is not replacing our standard way of evaluating cardiovascular risk. It helps in risk stratification in those individuals who are in the intermediate cardiovascular risk group. Remember, a CSE 0 does not rule out plaque in a diabetic patients because a large number of them have non-calcified plaques. So even if it's a CSE 0, but you have from a traditional way of assessing our patient's high CV risk, the patient might still deserve to be on a statin therapy. This is evolving. Some people have gone overboard by saying probably we should do a coronary angio or a CAC for every diabetic patient. I think we need to reserve that. It's not yet gone to that stage. These investigative tools are still meant for those intermediate groups for their assessment. So I end by saying traditional way of assessment stays. Probably we have already entered into the area of precision medicine with AI coming in a big way. with polygenomic score, probably in the next 4 or 5 years, we're going to see a complete change in the way we're going to assess cardiovascular risk from a population-based screening. We are probably looking at individual-based screening. Thank you very much. So I hand over to you, Sanjay.
Thank you very much. Amazing lecture, Samit. Loved your slides, but more than the slides, your content. I think it spoke so much of your own work that you've been doing over a period of time, and the news, the app that you have created, which probably becomes more realistic in our environment, because we always face with this dilemma that how do we really look at our patients when they have borderline values, and there's a lot of heterogeneity, as you pointed out very well, that should we be intensifying therapies or should we be continuing on the recommended targets that we always do? May I request you to stay on the platform, and we'll have a second speaker for the day, and then we'll take questions together. So we have with us today Dr. Vanita Aroda. And Dr. Vanita Aroda, I've heard her numerous times, and the last time I heard was in the ADA when I was really floored by the talk that she gave. And I said, I can't hold myself back and invite her to speak today over here. So thank you very much, Dr. Vanita, for joining us today in this evening on the edition of IDEC Cafe. Dr. Vanita is the Associate Professor of Medicine Investigation Criteria at the Harvard Medical School, Boston. She is the Associate Physician, Endocrinology, Diabetes, and Hypertension at the Brigham and Women's Hospital in Boston. She has had major administrative leadership positions. She is the Director of Diabetes Clinical Research Program, Diabetes Section Division of Endocrinology, Diabetes Hypertension at the Department of Medicine at the BWH, Director, Diabetes Research and Scholarly Activity Meeting, again at the BWH. She's a co-director, Endocrine Research Conference. She's associate editor of Diabetes Care and ad hoc reviewer in various journals. And she's been the recipient of various honors and prizes. I must admit, I don't do justice in this one slide for the 103-page CV that I received from her. But I think if I was to read out the entire 103-page, I think it would take the entire lecture time. But a lot of work that has been done by you, Doctor. But in short, I would just like to say that her expertise spans the full diabetes and cardiometabolic continuum, contributing to national and international clinical consensus. And Dr. Aroda is dedicated to representing the academic experience within patient-facing research and translating the insights gained through the clinical trial journey into broader knowledge and practice. This evening, Dr. Vanita would be speaking to us on holistic, person-centered approach to diabetes care. Thank you very much, Dr. Vanita, for joining us, and I hand this platform to you. It's a privilege and honor to hear you. Thanks a lot.
It was such a beautiful introduction. I'm very, very touched and I'm very flattered. Namaste to everyone, and I will go ahead and share my slides and make sure that all is good to go. Well, let's start at the beginning, not at the end.
We can see your slides.
Okay, wonderful.
Can you make it full slide? Yeah, that's good. Yeah.
Okay, let's dive right into it. These are my disclosures, which really reflect the opportunity and involvement in many of the large trial programs in the diabetes space. So I've broken it up into 3 areas of, the scope and call to action, the shifting paradigms that we are all actively living. And I think the last presentation exemplified that really well, that things are changing really rapidly in terms of how we're looking at patients and how we're looking at life course. And then I've chosen a few kind of emerging conversations to represent some of these changes. So the call to action, what we are seeing, not news to anyone, but we are seeing rise in levels of overweight and obesity around the world. India is not exempt to that. The US is not exempt to that. We are seeing it everywhere, and we're seeing this ramifications of that. We're also seeing that despite this knowledge, despite the number of therapeutics and things that we've had for decades, we're still not following the basic fundamental, which was demonstrated in the UKPDS, that if we can get people to goal and keep them to goal, we can prevent complications. In the US, for example, only 20% are actually treated and controlled, at levels. The rest, there are gaps. India is no different. So, in terms of the number of people that are undiagnosed, or the A1C, whereas at goal, blood pressure's at goal on lipid-lowering medication, there's a lot of opportunity. The other shift that we're seeing in the world is less emphasis, I would say, on lifespan itself and more emphasis on quality of life. So health span, being able to live life fruitfully without disability. And if we look at the leading contributors to risk factors, it used to be iron deficiency, smoking, other areas. But now we live in a cardiometabolic world where glucose and BMI as the indicators are driving health morbidity and health span, the quality of life. So who would have thought that it would all come down to endocrinology and everything that we all cover in terms of approaching the patient. We also see key demographic shifts in type 2 diabetes. Geographically, we're seeing that type 2 diabetes is a global epidemic, rapidly increasing in low and middle income countries. We see that type 2 diabetes is now occurring in younger populations, and that creates its own burden and aggressiveness. We see that, with the greater number of the cardiometabolic risk factors, the further we're pushing the early onset of type 2 diabetes. We're also seeing an increase in both younger and older adults, and both have different nuances in what we might be considering. And for example, in younger individuals with type 2 diabetes, we see weight trajectory as an important determinant of type 2 diabetes. We see an increasing impact of socioeconomic status on the ability to support people, and we're also seeing, as people are living longer, their exposure to the glycemia, the exposure to the obesity, the exposure to these excess burdens is actually altering their trajectory, the development of multiple long-term conditions, but also the trajectory of other underlying morbidities that they may have. So the scope and call to action: there's a global rise in diabetes and obesity that drives an increase in complications and multimorbidity, differentially affected by socio-demographic factors, affecting health span and quality of life at the individual and population level. And all roads lead to holistic prevention. That's kind of the nutshell. And, in terms of quality of life, I don't know about you, but here, if you ask patients, what is it that's most important for you? A lot of times the answers we get are, I want to dance at my daughter or dance at my granddaughter's wedding. So all of this impacts the quality of life. So shifting paradigms in type 2 diabetes care. We are all building off of the shoulders of the great giants before us. So the very first guidance in 2006 in type 2 diabetes care really leveraged what we knew about from the UKPDS, and that is at diagnosis, lifestyle intervention plus metformin. And then after that, you can choose your different medications. But they admitted that the primary goal was achieving and maintaining glucoses, but we didn't necessarily know what the right way was. In 2009, we had the emergence of less validated therapies, quoting the paucity of high-quality comparative research, and that's changed. We now have lots of head-to-head trials where we do have comparative research. 2012, in terms of the consensus, I call this the dim sum menu, where now we have lots of medications and lots of profiles of medications. But do you want a little bit of hypoglycemia or a lot of hypoglycemia? So it's a lot about the medication profiles with the explosion of therapies available. But what we also saw, courtesy of Accord, VADT, and Advance, is that not one size fits all. Not everyone needs to have aggressive, intensive therapy down to low A1Cs, and that the patient characteristics and profiles could impact treatment goals. Fast forward, a big shift happened in 2018 after the cardiovascular outcomes trials, where we saw that we actually had the ability to affect outcomes. And so then it was starting to understand the different phenotypes of the patients. Do they have ASCVD or do they have high risk? And I've been privileged to be part of the 2022 consensus, and I'm also part of the 2026 consensus that's ongoing. For the first time ever in any guideline, we use the term holistic, where we said, in diabetes care, yes, we're addressing glycemia, but we're addressing the whole picture of everything that can affect their outcomes. So we look at weight, we're looking at cardiovascular risk factor management, we're looking at cardiorenal protection. And this again, it was the first time we've seen in writing in large consensus statements the focus on holistic, person-centered care. And I think what we're going to see in this next iteration, as these dialogues continue, just an expansion of what that possibly means. So I wanted to share with you, these are personal thoughts of where I think we're going. I put this together before some of the current conversations. So I think, and again, the previous lecture captures this really well. In this next dimension of holistic care, I think one dimension is the longitudinality, where we recognize that we have the ability to affect the life course of an individual even very early on. The AHA did a beautiful job in creating this model of the stages of cardiac kidney metabolic syndrome, and even left room for primordial prevention, even when people didn't have stage 1, stage 2, stage 3. At the last international consensus, the Lingvei et al. Paper really informed some of our discussions, where we said, you know what? It isn't about just a glucose-centric approach downstream. We need to think about the upstream modification to affect the long-term metabolic course. So towards longitudinal trajectory, even now, even in someone who doesn't have diabetes, we know that if you look at the life's essential 8 factors of 4 health behaviors and 4 risk factors, every 1 standard deviation increment of the life's essential score is associated with the lower odds of cardiovascular disease of a reasonable magnitude. I don't know if anyone's gone in, but it's worth going into the website and calculating your own score. And you can see how simple it is to see how these different factors impact the longitudinal course. Similarly, a 10-point improvement, and some of these are very modifiable, can prevent 9.2% of MACE, and repeated measurement over time indicates cumulative exposure to the full cardiovascular health risk factor burden. So I think we are moving in the next iteration towards longitudinal assessments. So I've chosen 5 emerging conversations which I think highlight other aspects of holistic care. So one is this concept of type 2 diabetes remission. I'm not going to focus on remission per se, but to say that, you know, we were taught, and I think one of my own mentors is on this call, that, you know, diabetes is chronically progressive. But I think now we are realizing that the biology can go both ways. So I have 2 vignettes. First one is a 31-year-old South Asian male in my clinic. He moved to the US from India, from Mumbai. And in India, he had a new diagnosis of diabetes during a great time of stress. His A1C was 12.8%, glucose was in the 400s. He was treated with metformin. BMI was not obese by international standards. It was 26. Now I manage him. He's fully off all medications. His BMI is 24. His weight is down. Is this remission? Are we cured? Does he need long-term follow-up? Does the lower BMI affect treatment approaches? So, you know, he's off medications, so he meets the ADA criteria for remission, but he's not out of the woods. So I keep a close eye on him, check in A1C every 6 months, and he fluctuates. His mother comes visiting him from India and starts making all his favorite dishes again. And you can see the first thing that goes up is the triglycerides and the weight, and then the A1C follows. And then, you know, we have a visit, and he kind of rediscovers the healthy eating all over again. Another patient, 56-year-old with type 2 diabetes, he's treated with metformin, GLP-1 is added. His A1C goes from 8.9 to 5.3%. He finds that it's much easier to start incorporating healthy lifestyle. I call this self-efficacy, where it's just suddenly easier. He asks me, am I in remission? Can I stop my medicines now? And I think, you know, another area for conversation is there really a difference of remission versus highly effective control? I tend to think that whatever you do, and based on some of the data, to get people and keep people under control bodes well for the long term. So I say, okay, we can experiment, we can cut down, we can see what happens. And sure enough, as you know, when we take away the incretin, or if we decrease the incretin, his weight goes back up, his hunger signals come back up, and you know, we found a happy medium of the right dose that works for him. So the ADA a few years ago put a consensus definition together for type 2 diabetes remission. They said that it's an A1C of less than 6.5%, at least 3 months after cessation of glucose-lowering pharmacotherapy. And what I want to say is this was really to standardize the nomenclature internationally for comparison across trials. This is not a concept that I personally would dangle in front of a patient that, oh yes, you can get rid of your diabetes forever. You're permanently cured. You know, the closest we have to that is metabolic surgery, but even then, people still remain at risk and you still need to follow them and keep a close eye. The direct study is a really nice illustration of kind of the benefits and challenges of aiming for a remission. So this, as you know, has looked at adults aged 20 to 65 with type 2 diabetes within the previous 6 years. Their baseline A1C was not terrible, it was 7.5%. But what they did is they took them off all of their diabetes medications, had them undergo a dedicated weight loss program, aiming for at least 15 kilograms of weight loss. That's a pretty sizable amount from a baseline weight of 101 kilos. How did they do that? With total diet replacement, so 825 to 853 calories per day. Again, before you start dangling a remission carrot or even talk about that, you yourself need to start on an 800 calorie diet and see how you feel first. And then they had structured food reintroduction. And what they found was the first proof of concept that, again, diabetes does not need to be progressive. It can regress. So 46% achieved diabetes remission, and that ability to achieve remission was directly dependent on the magnitude of weight loss. So the higher the weight loss achieved, the higher the remission. What we saw at 2 years, though, again, the likelihood of sustaining that remission decreases, but is maintained in those who maintain the high degree of weight loss. What they also found, again, pointing to the regression of biology itself, is that when they looked at MRIs, there was an increase in pancreatic volume. You know, at baseline, there were these ratty pancreases, but they ended up more kind of full and more non-diabetic looking in appearance. They had increase in maximal insulin secretion and normalized regularity of the pancreatic borders. So the author said that for the first time, reversibility of abnormal pancreas morphology of type 2 diabetes was shown with weight loss-induced remission. But now let's take a look at the same participants 5 years later. So these are people who volunteered, who wanted to sign up to have a low-calorie diet for remission. By 12 months, 10% withdrew. By 5 years, 40% withdrew. So the question is something like that that's so stringent, is it sustainable? Is it patient-centered? And that's what we need to remember, is we need to meet patients where they are. And certainly enough, if you look over 5 years, those who initially had the intervention, regained weight, you see the curves coming together, the percentage of remission goes down, it's still better than at the beginning, but you start losing some of the effects when you start losing the sustainability. And even the authors in their discussion said, not all people will succeed, but maybe we need to think about more integrative approaches. It isn't all or nothing of one or the other. Now, in the South Asian patient that I shared, he had what some might have considered a normal or low BMI. So I pull up this study by Roy Taylor, actually in front of my patients, and I say, there could be a personal fat threshold hypothesis. There's a reason you have high blood sugar. Likely for you, you have that tipping point of too much visceral adiposity where the circuitry is not working as well. And this proof of concept is pretty impressive in my estimation. So they took people with non-obese BMI and put them, again, proof of concept, on a low-calorie diet, 800 kilocalories per day, and took them off of their medications. So in their 20 patients, baseline BMI of 24, 70% achieved remission. So this is in normal BMI individuals. And by imaging, they had reduction in intrahepatic, intrapancreatic fat percentage, as well as improvements in fasting plasma levels. What they found was that even in this normal BMI population, remission was possible with weight loss, and that the threshold of remission was achieved with a median weight loss of 6.5%. You didn't need these huge 10, 15%, 20% weight loss. It even played an effect in normal BMI, type 2 diabetes. So next conversation. So the sum of that is, there's a longitudinal course, regression is possible, but we still have to keep an eye on patient, and weight does have something to do with it. conversation number 2, the incretin journey continues. My goodness. I was at UC San Diego in the VA with Dr. Medallier and Dr. Henry when, we were doing the first studies with exenatide. And the first approval, we were celebrating that, wow, we had an improvement with A1C. People lost 2 to 3 pounds, and that was a huge success. But since then, I call this the unfoldment, the self-unfoldment of GLP-1. We've seen approvals for and indications for weight loss, for heart protection, for kidney protection, for liver protection, for sleep apnea treatment. And, now we're entering the next era of what else can we see with more proximal addressing of underlying biology. But I want to share that the conversation is going to continue to evolve. So the incretin journey continues. This is a 42-year-old male with type 2 diabetes. His BMI is 32, A1C is 9%. He has biopsy-proven MASH at stage 2 to 3 fibrosis. He's on an antipsychotic known to promote weight gain. He's a former master chef. So he enjoys sweets, he enjoys food, he sees his primary care provider, he sees the weight management clinic, he sees the liver doctors, and all of them are focusing on his weight. And he's really reluctant to lose weight. He then sees me for diabetes, and I don't talk about weight at all. What I do is I show this study. This is from the Surpass 3 study, the sub-study looking at liver fat. And what they found was that even in people with routine diabetes, there's a high percentage that had high elevations of liver fat. And with the tirzepatide compared to insulin, you could see an improvement in liver fats from baseline. This is one participant went from 27.3% down to 2.6%. The moment I showed him a picture of this liver and the liver change, he started doing anything I say. He started taking the medications as prescribed and did lose the weight. But my point is that we have to know what we're treating, and we have to know why we're treating it for patients and bring them to the same page. So talking about weight alone is not sufficient. We need to cover the why. There's lots of evolving conversations with GLP-1 from all the different safety areas of interest, some of which have panned out, some of which have not panned out, that we all need to be kind of well equipped because patients have the same access to information as we do. And we need to help them sort through the evidence-based information. In addition, prescribing GLP-1s is not just about managing side effects of, nausea, fullness, but now with the next potency of agents that are available or will be available, we need to make sure we have an understanding of what's going on with their muscle mass, what's going on with their exercise routine, are there any risks of nutritional deficiency, are they getting adequate calories, adequate hydration. So this, again, is going to evolve. I have found that my own conversations with patients with GLP-1s in terms of considering the conversation has changed. Number one is before introducing, I share that it's a commitment to a nearly lifelong therapy. It's chronic therapy to manage a chronic underlying disease. And so, having that transparent conversation of if these medications are stopped, as we've seen in some of the studies, we typically see a resurgence of the weight gain, a resurgence of the A1C, blood pressure, C-reactive protein, and that an important part of the success, the longitudinal success, is having readiness for lifestyle change, diet, physical activity, muscle, and resistance exercises. Okay, so conversation number 3, another way I think, another dimension of holistic care is I think we're at a point where somehow we have all these labels, but we need to have a better understanding of what we're actually treating. I use this as an example. In 2025, the ADA put this really nice elaborate chart for approaching the patient with type 1 diabetes. Yes, there's clear-cut, islet antibody positive type 1 diabetes, but there's also not clear-cut situations. Someone could have a low age of onset, but they could have a family history of type 2. They could have increased BMI. They could have, other risk factors suggesting that there's actually insulin resistance at play, more type 2 physiology. So if it's unclear, you make a clinical decision how you're going to be treating them based on what you know of the whole picture. So I think what we're going to be appreciating more is that no two patients with type 2 diabetes as well are alike, and there's a full gamut, and understanding more of their physiology will be helpful. Here's just my anecdote in this vein. So a 76-year-old male, he was diagnosed with type 2 diabetes in 2012. His BMI is 26, not obese, but if you look at him, it's a central distribution of his adiposity. His A1C is 7.9 to 8.6% despite treatment with 3 medications, and his glucoses are noticeably higher in the morning. So if you look at this, he's got really strong dawn phenomenon on professional CGM testing, rise in glucose of about 40 points, and it lasts throughout breakfast. What else about his whole picture? He's got hypertension, he's got 3 medications, he has primary aldosteronism. Just for the blood pressure, he's got hyperlipidemia, specifically elevated triglycerides. He's got incidental calcifications that are seen on CTs. He has a CT cardiac calcium score suggesting significant underlying CAD with an Agatston score of 1497. Again, someone whose BMI is only 26. So what is going on? What are we actually treating? Income hypercortisolism, that's another dimension, is we know that hypercortisolism has multiple manifestations of the cardiometabolic phenotype, from diabetes, obesity, CVD, dyslipidemia, blood pressure, and osteoporosis. So he's someone who we did the overnight dexamethasone suppression test screening. He was involved in the Catalyst trial. So he's on 3 medications, had an elevated A1C despite this, fasting glucose that was elevated. And on the 1 milligram dexamethasone suppression test, his morning cortisol did not suppress. It was 2.41, and the serum dexamethasone level was within range. On further evaluation, his CT of the adrenals showed some nodular thickening. Aha, the plot thickens. So it turns out that he's not alone. When we looked at the full cohort of over 1,000 individuals with what we characterized as difficult to control type 2 diabetes, meaning they're on multiple medications, A1C is not at goal, or they already have evidence of complications, we did the screening test with the dexamethasone suppression test and found that 24% of this cohort, which is a high number, had underlying hypercortisolism. It was even higher in people who are also taking 3 or more blood pressure medications at 36%. And not everyone had an adrenal abnormality, but definitely people who had hypercortisolism had greater underlying cardiac disorders. So are there aspects of physiology that we're missing, or that we have been missing traditionally? Again, as a proof of concept, followed the second part of the Catalyst trial, where people were randomized to a cortisol-directed therapy with mifepristone versus placebo, showing a sizable reduction in A1C, a net difference of 1.32%. So the better we understand the underlying physiology of the individual patient in front of us, I think the better we will be off with being able to target appropriate tailored therapy. So conversation number 4, again, these are all emerging. These are all emerging. Is all obesity the same? I've been privileged to be part of the standards of care in overweight and obesity as well. And, we defined obesity as a chronic, relapsing, and progressive chronic disease requiring long-term, multi-component treatment strategies to improve the health and well-being of individuals. And these, the process has been focusing complication-centric, meaning trying to reduce and not just focusing on that single number of weight alone. The South Asian phenotype has provided so much understanding, not only from the books, but even when I look at my own family history and, when we understand ourselves. So you can have 2 people with the exact same BMI, but, if that adiposity, if the quality of it is more visceral and ectopic, then you have dysfunctional adipose tissue. You have higher risk for type 2 diabetes, hypertension, heart disease. We also know, again, from the Masala and the MESA studies, that in South Asians, we tend to have higher visceral fat, higher intramuscular fat, less lean mass to begin with, and greater fat deposition in the liver, and less of the, insulin sensitizing hormones such as adiponectin. And even at lower BMIs, a very, very high prevalence of NAFLD or MASH in the South Asian population. So there's a difference to begin with. So, focusing on weight alone may lead us astray. Another example, and I try to remember this when talking with patients, is one can be obese but cardiovascularly fit and be at less risk than someone who's normal weight but not fit. So cardiorespiratory fitness is an achievable goal, from where patients are at, it is an area of focus and is an area of emphasis because it isn't about weight alone. The more fit one is, the less risk they have, period, across all weights, in both men and women. With the international consensus, for the first time, we broke down the 24-hour physical activity behaviors. It isn't about everyone, having their gym outfit ready and running at the gym and sweating up a storm. It's sweating, it's breaking up sedentary time, it's your step count, it's quality of sleep, it's resistance training and strengthening. All of these 24-hour activity behaviors are associated with improvements in metabolic state. Now, causal studies are less, but the associations are there. Another thing that I've learned from one of my colleagues, Dr. Saeed, who focuses in obesity medicine, is with our patients, again, shifting away from the weight to thinking about non-scale victories. Are you able to do a few more steps now than a few months ago? So really focusing on the full holistic picture beyond a single number alone. In addition, we know that there's the obesity paradox, that in certain populations, lower BMI may actually be associated with higher rates of mortality. As a case in point, the Origin study, which we're all familiar with, these are people in their 50s with type 2 diabetes, and they were assigned to placebo or insulin glargine. Look who had the highest risk. The highest risk was in those with the lowest BMI of less than 22. The sweet spot, the lowest risk, was actually in those who had moderate obesity, 25 to 35. So know your patient, know whether you're in a primary prevention state or if they're in a state where weight loss, you want to preserve muscle mass, and maybe that level of weight loss is not desirable. There has to be intention to what we do. So what we manage now clinically is the tip of the iceberg. We manage the clinical risk factors, but what we really need, again, a shout out to the previous speakers, we need the full picture. We need to understand the Lp(a), the other atherogenic contributors, their cardiopulmonary fitness, their physical activity, social determinants of health. And that's the exciting part of the next decade, I would say. My last conversational point in terms of holistic dimension is, I think more and more we're appreciating that lifestyle truly is medicine. So we're familiar with the Predimed study looking at Mediterranean diet on cardiovascular outcomes. This was a primary prevention study. So adults aged 55 to 80, no CVD at baseline. They had type 2 diabetes with at least 3 risk factors, were randomized to a Mediterranean diet or to control. They had improvements in inflammatory markers, improvement in lipids, had a really nice diet consisting of nuts, vegetables, low-fat dairy products, and extra virgin olive oil, and a sizable 30% reduction in the primary endpoint of composite cardiovascular events. Very impressive, at our disposal. I think something to think about is, you don't have to abandon your own diet. The Indian diet, the South Asian diet, if you think about our grandparents, great-grandparents, they had the healthy diet, they understood it. And so, how can you Mediterraneanize the Indian diet? It's very doable and it's very flavorful, and it's just some healthy swaps and portion control throughout. My last study that I'll share on this topic, this study has stuck with me in doing my own literature review for the next consensus. So this is a study in China where they took individuals with type 2 diabetes with normal cognition and randomized them to 1 year of aerobic training versus control, where they maintained the usual activity. The aerobic training was 60 minutes, which included a 5-minute warm-up, 50 minutes aerobic dancing with music, and 5 minutes of relaxation training. And they had increases in the total hippocampal volume, right hippocampal volume, as well, and improvements in the mini mental status exam and MoCA mental cognition scores. So we are no longer just treating A1C, body weight, etc. We're treating, healthy aging. We're treating the longitudinal trajectory. And with that, I will say thank you. We are all living this shifting paradigm together, and there's lots of emerging conversations, and it's great to be a part of it. Thank you so much.
Thank you very much, Dr. Vanita. I think that was a wonderful lecture. And I'm sure we're going to have a very interesting conversation for the next couple of minutes and address some of the key questions. So I'm actually going to start off with some of the questions that we have received from the audience. And I would also like to thank Dr. Sundar Mudliar to join us today, and I hope he's going to be part of the conversations. Welcome, Sundar, to the show. So let me start by posting to you the questions that have come to us. This comes from Dr. Jain, and I think this will be addressed to Dr. Samit. That do conventional risk calculators underestimate CVD risk in diabetic patients? Now, I think this conversation comes from the point that most of the risk calculators take a large cohort of population from the Western data. We have very small data that comes, into the calculators that has been widely publicized, and we even the Q risk score for that matter. So if you take a small cohort and extrapolate the larger heterogeneity which is there in the Indian population, would you have a very similar result that you see in the Western cohort of populations? And I'll ask Dr. Vanita to also give her comments about this, because we don't have major populations that have been represented in these risk calculators.
So you're asking me, Sanjay?
Yeah, Samit, yes.
Yeah, okay. Yeah, I agree with you. But I think of all the risk calculators, the Wikipedia's risk score, which was later, I think, upgraded into QRisk, had a significant amount of the Asian ethnicities. And they had the different types of ethnicities. They had the Bangladeshis, they had the Pakistanis, they had the Indians. Now, you might say a large proportion of them were from UK. They were not from India per se. So if you want to make that distinction, then I agree with you that the Indians from India were probably not studied as such. But the Indian ethnicity, if you say, the Asian ethnicity, the Indians, the Bangladeshis, there was a large representation. As a matter of fact, Curious with the Wikipedia's risk engine had 33 publications, and from the Asian cohort, there are 4 or 5 of them which were published. Having said that, once you get that more than 20% risk profile, your job is done. The problem is in the intermediate risk profile when we're between 10 and 20%. What do you do? Now, this is a very difficult area. And as I showed you in the presentation, that CAC is coming up in a big way. It's being endorsed in a big way to settle that part of the question. Inflammatory markers are coming in slowly. Highly sensitive troponin and HSCRP can complement, those areas. Yes, it is overestimated. As Dr. Vanita was also saying, and I was also trying to point out that this is a point in time. It's like a point of care estimation of your HbA1c, a point of care estimation of your risk. The entire cumulative, the risk that you have left behind you, the years, they have not been taken into consideration. However, duration of diabetes of more than 10 years, family history, those are very well represented in QRIS-3. So I think if you're at all using it, QRIS-3 is not that bad a risk score as many others are probably.
Dr. Vanita, you belong to both the worlds, so I think
Yes, literally. And even in other world as a patient. So I'm of age. I'm 52. Believe it or not, Dr. Mudaliar. When we see the doctors, they say this is an evidence poor zone. But I'll tell you, there's some really nice work being done in the U.S. So there's the South Asian Heart Coalition in the Bay Area in California, and they have a nice cohort of South Asians that they follow over time. They recommend coronary artery calcium score for those above the age of 40 from the South Asian diaspora. They recommend the C-reactive protein, the lipoprotein A, and including a HOMA-IR insulin level to really get the full picture. So I think what it is getting as much clues as we can, taking some of the risk engines with a grain of salt, but distilling it back to the patient in front of you.
So if I have to come back to both of you, today we not only talk about, risk markers, but we talk about plaque morphology. And you have, people with very low 30, 40% plaques, but lipid-rich plaques, which tend to ulcerate and cause MIs, far more than probably people, who have a more advanced stenosis. And these are the people whom we're really not looking at aggressively, because, there's no way we can diagnose a lipid-rich plaque. And, unless you do an IVUS or an OCT or something and find that out. So how are you going to lower? I mean, I have seen populations of people if you look at all the traditional risk markers and the newer markers that we're talking about, FLPA and ApoB, and trying to, I mean, calcium scores will not really reflect that at that point of time. How are you going to at least have in a busy clinical practice? Is there some way that you can identify these high risk populations who will be at a high risk to get maybe an MI at a younger age or a middle age without going into very lot of evaluation of the risk markers? Dr. Vanita, your thoughts, and then I'll come back to Samit.
I think there's a lot of value, and in fact, there is a statement put out in the fall of using HSCRP. So that kind of, it's a close proximity of, is there acute inflammation going on? And then at that point, again, if we're talking about type 2 diabetes, if someone's South Asian, you've got plenty of reason to think about the SGLT2 inhibitor class or the GLP-1 receptor agonist class. And you can actually follow the CRP over time, which I do in some individuals if I think it might change my management. So, checking where they are in the beginning, incorporate your intervention, whether it's statin care or, the cardioprotective agents, check a follow-up, engage the preventive cardiologist, and then decide in that way. Will there be a role for, CT angiography in specific populations? I think that's yet to be determined for care.
Sanjay, can I ask a question to
Yes,
Vanita?
please go ahead. Yeah, that's Dr. Guillermo on that.
Yeah. Vanita, well, thank you so much for your amazing lecture. I've been thinking for quite some time that following the recommendation of the ADA standard of care, this paradigm shift have moved from cardiovascular protection, renal obesity, and move all the way to the right, if you look at that graph or the algorithm on glycemic control. And I'm afraid that the importance of glycemic control and lifestyle intervention has been lost in primary care. And if you look at the standard of care guideline, the algorithm, I mean, if you look at the section on glycemic control, is 1/5 of the whole algorithm. I mean, if it would be me, I would move the glycemic control to the left, because the mother of all the complications of diabetes is hyperglycemia. Would you care to comment?
Yeah, I'm afraid to comment too much because I kind of know what's to come. But you're right, Guillermo. I can talk about the previous iteration. The intention of putting healthy lifestyle up front and glycemic management up front in that circle was so that we remember that it's actually part of the background. It's there the entire time. And I think that you are correct that we need to reemphasize that these are the important basic tenets that need to be revisited every single visit throughout the life course. So we're thinking of ways to graphically represent that in the next iteration.
Yeah, I mean, I think that glycemic control and weight should be moved to the left and cardiovascular renal to the right, because that's the day-to-day care of, like myself, who treat a lot of indigent patients, low income. I mean, it's a dream. It's a fallacy of thinking that the GLP-1 is for everybody, it's going to cure everything. And it's not true. The discontinuation of this medicine is quite high and not accessible to most of my patients.
No matter what, and we learned this even in the diabetes prevention program, like pre-diabetes, no matter what, just get people to a good level. Doesn't matter what you choose. So I call it keeping the eye on the prize. It isn't the actual medicine, but it's actually, what the goal is.
So yes,
I love both lectures were superb. Thank you.
So Sanjay, I think it's a world of narratives, right? So in the zeal of selling a GLP-1 and SGLT2, I think we have commonly come across the statements that the benefits are irrespective of weight loss, irrespective of baseline weight, irrespective of baseline weight, irrespective of baseline A1C. That doesn't mean it is irrespective of weight loss or irrespective of HbA1c lowering. So when we published our meta-analysis in DRCP, we showed that there's significant heterogeneity in the MACE outcomes with the GLP-1 based therapy, which was not explained by the weight or systolic blood pressure. was significantly explained by HbA1c lowering. So it's HbA1c lowering plus when you put people on GLP-1, you're getting the benefit. So the narrative is not that you put GLP-1 and everything is taken care of. There's no need to have a glucose under control or your blood pressure under control. That's not the, so irrespective of baseline doesn't mean there is no need to alter the baseline. If you have the baseline which is above your target levels.
So, Samit, let me come back to you. That today we talk about cardiovascular risk in younger individuals, and we're seeing in the second decade and third decade, and you're looking at all the youngsters with bad lifestyles, and we conventionally ask statins to be given above the age of 40. Do you think we should lower the age to start statin therapy and not be so fixated about the fact that we should start above 40, for patients who have diabetes? So, what's your comment on that?
Sanjay, we need serious dialogue in our country. We can cut down things. We have cut down the BMI to 23. We have done away with obesity. We have converted from 10% to 40% of our population as obese overnight. From January, the cutoff was 25. In March, the cutoff is 23. So 15% of Indian population being overweight suddenly becomes 40% obese. Now, you can keep on cutting those down, but as I think Dr. Vanita was also showing in the presentation, we are going upstream. We are no longer talking of hypertension, dyslipidemia leading to MI and stroke, leading to secondary prevention. We are trying to go even further up, addressing the visceral adiposity, catching those people who actually don't come to a doctor because they just have this excess adiposity, have not yet developed the disease. That's the majority out there. It's a public health problem. How do you go there? You and me sitting in our chamber won't be able to capture these people. In India, if you have a health policy where you need to screen yourself at, say, above 35 years of age, with a certain risk profile, that's fine. But as of now, we don't have a consensus. We are still, I think, dependent on international cutoffs that are given to us. So we need to work on that, I think, a little bit more.
I think that stems from the fact that we don't have a universal data collection in a country to really know what our normal cutoffs are. I mean, we keep saying that, we go by the Western norms to say these are the cutoffs that are extrapolated. So when we all sit to make guidelines in India, we are taking Western cutoffs to really extrapolate to our own population. But unless we do a hard data collection and look at longitudinal studies to see what are actually the tip of, where you actually get a high risk, then you can probably customize our treatment to Indian standards. Perhaps I think that's where I think we need to really focus in terms of public health. I don't know what Sundar, let me draw you into the conversation, and what do you say? So again, you're part of both the worlds, and you have your hand up there too. So what do you say? You've done a lot of work in this area.
Yeah, first of all, I wanted to congratulate Dr. Vanita. We in San Diego are extremely proud of her accomplishments, her achievements. Almost every month, I point out to my fellows, hey, we have a great fellow, former fellow. So we're really, and above all, she's very humble. That's the big thing. So I want to big shout out to her. Second is, I mean, I've been following it, lots of, thoughts and everything. But one thing is CVD risk in India. Is it really higher than everybody else? I think yes. And, there's a big, even in India, I won't take too long. I know other people want. It's rural versus urban. Then the Indian in India, the Indian overseas, and also the Indian overseas in Singapore or UK versus the Indian overseas in the US. And about 20 years ago, we did a study over here. Just Anup Mishra did about, I believe it was 500 people, urban and rural area. There was a rural area in Madurai. There was an urban area in Delhi, one of the slums. We did it in the US. And we found what we find. For cardiovascular risk, for other things, there's a clear difference between rural India, urban India, between urban India and Indians in the US. Now, what is it nature? Is it nurture? We don't know. And when they first did the studies in Singapore many years ago, so in Singapore, you have the Chinese out of China, the Malays out of Malaysia, the Indians out of India, and clearly the highest risk is India. I don't know what it is. I mean, you're all talking about now statins for primary prevention in Indians. What cutoff? And I just want to say that risk, like both Dr. Vanita and Dr. said, it is a linear relationship. and that area under the curve, which your accumulated burden is. I think that's the big thing. If I may make one last point over there, and Dr. Samit, you alluded to it. It's not the weight. It is something else with the GLP-1. And classic example is the Harmony study with albiglutide. Nobody even talks about it. They did not lose weight, but they had 1 pound or 2 pounds. They had cardiovascular benefit. It has been buried, that study, pointing to the fact that it's not the weight. And Dr. Vanita also very nicely alluded. Don't focus on one thing. Get the whole picture. Thank you.
I think that was a great comment, Sundar, and really appreciate your feedback about this. But are we now moving, both of you talked about precision medicine and futuristic medicines. Uh, are we now getting more and more there with all the AI algorithms that we are incorporating to find out which are the populations of people that we are going to really intensively target? And that's perhaps more because of we need to have a very cost-effective resource in our country. Not everybody can afford all the tests, not everybody can afford all the medications. And, the guidelines are great to say. But what are we going to do for the vast majority of the population in the country? I mean, how are we going to approach this problem more effectively? So, Vanita, to you, and then to Samit again.
We've seen an example of this with tobacco, right? Where there is a nice cultural evolution of, recognizing that there's a public health impact of tobacco use. And I think, in my visits to India, everyone said, you're not healthy enough, you're not chubby enough initially. So I think it's changing the framework, changing the expectations. Instead of actors holding up a bag of Lay chips, maybe they should have a bag of apples. So I think there's a lot of public health awareness. And then beyond that, it isn't about which drug, it's about making sure that patients have the choices to support their goals. So I think we need to think about this in an intersectional way across the different sectors of society to make a difference. It isn't going to be about a guideline saying choose this medicine. It's going to be about something else.
Samit, your views?
So from the busy clinician's point of view, right, I think the first thing is if you cannot use a risk calculator, look for risk enhancers. Simple history is the duration of diabetes more than 10 years. Are you having albinuria? Take a family history of premature CVD. Are there other symptoms of metabolic syndrome? Do you have skin tags? Do you have other features? Look at the waist circumference. Look at triglycerides. Look for target organ damages. These are few things which can be done in clinical practice. People are coming with bunch of investigations. You can look at their HSCRP. I know NT-proBNP is extremely costly in India, so might not be required for all patients except in those scenarios. Pay attention to diabetes specific risk factors. Look at, say a duration of diabetes. What is the level of glycemic control? Apart from doing a BMI, look at the waist circumference. Probably a waist height ratio is quite a good thing because it's standardized across all races. So it's probably a better way of looking at it. So I would say for a busy clinician, it's a 5-step clinical framework. If you can do a risk score, if not, identify the enhancing risk factors, look for target organ damage. If you are indeterminate anyway and you have the facility, go for a CSC scoring. And most important, intensify preventive lifestyle. It's not only for preventing newer metabolic disease, but even go for disease reversal, as Dr. Vanita was saying, with a good amount of weight loss. So I think those are the 5 tips for a busy clinician that I would like to give.
I loved your life's 8 essentials, Dr. Vanita. I mean, that's now become, of course, the standard of care that we need to do in our clinical practice. We have often people who come to us with they're sort of phenotypically thin, metabolically fat, and we call them, lean fat Indians that we've got. Now, and we've got the other extreme who are really obese, but metabolically, not so bad as such. We have a whole spectrum of people in our clinical practice. Can you tell me just 5 investigations that a clinician should do, which will highlight that both the spectrums are covered, and we can say that we are at least estimating a reasonable amount of risk in an individual who should go for further evaluation? Because we need to have this in a clinical practice that, okay, we have both the ends of the spectrums, but how are we going to have at least a baseline evaluation which will tell us that your next step is going to go to choose which patient should go further for more advanced therapy evaluations.
I love Dr. Samit's framework, I'll say. But, taking the two polar opposites, I'll say I look for evidence of insulin resistance. Dr. Samit pointed out a few, the skin tags, the acanthosis nigricans, but also triglyceride to HDL ratio. It's there, it's available, it's an indicator. Insulin is not recommended as a standardized, but in some cases the HOMA-IR and the insulin level is helpful. And I think again the South Asian phenotype is thought-provoking that it does help. So that's kind of one set is what am I actually dealing with. Then the second set is cardiovascular risk assessment, Lp(a), CRP, family history. There's nothing more than what you've inherited, just to know about to try to lend granularity to timing and intensity. We know that these medications will work. At lower risk, you see a lower absolute risk benefit, but you still see relative benefit. So thinking about what the timing and intensity, looking at family history is one. We have a similar model with colonoscopy screening, right? If someone has family history of colon cancer, you screen earlier in this patient population. So I think those are kind of my two. And then the third is level of obesity. I look at three things. I look at glucose, I look at blood pressure, and I look at liver tests. And I know we look at FIB-4 score, and that's the integrated score, but I actually like looking at the raw trend of the ALT and AST over time, because you do see that going up and down as the entire metabolic picture improves. So that's kind of my three-pronged classification.
Where would you put it? I mean, how often would you think that albumin creatinine ratio would be something, because we have ignored albumin urea as a very important marker, and we haven't been talking about it at all. That it's at the end of the day, it itself is also by standalone a risk marker. So uh, how would you rate albumin urea as a risk marker?
It is, but I tend to see it surface later in the course. So it's great in that kind of stage 3 subclinical area, but I typically have not seen it emerge as a risk marker in the early course where you're making some of these primary prevention decisions.
And now, of course, with Google coming in and looking at retina as a cardiovascular risk, your comments on that, Samit, you're laughing. So
I'm reminded of a 10 years back incident when myself and JJ had a personal social evening with Dr. Mudaliar, and he shared one of his slides, which today coming back in a big way was the epicardial fat tissue volume, if I remember that correctly. One of the reasons why probably we are getting these cardiovascular benefits with GLP-1, even with minimal weight loss of 2 or 3 kilograms average, is because you have only 130 to 150 cc of epicardial fat volume. So you need to reduce a little bit of that because they're highly metabolically active to get. But if you think of it from the MSLD point of view, you're looking at liters of fat in your liver. So, in order for a reversal of MSLD, you're probably going to need a huge amount of weight loss to get that thing. So I think the assessment of internal fat visceral adiposity through waist, I think waist circumference is extremely underrated. It should come into all the guidelines along with the BMI. And assessment of internal fat, I think with the new guideline putting in MSLD, we should look into it big time with the FIB-4 screening and going for the TE and the CAP, because that tells us about what's happening inside.
Sundar, your comments, since he quoted you, so your comments on that.
It was purely a serendipitous observation at that time. Now, of course, it's taken on a life of its own, all the fats, in the different depots. But I want to pose a question. People talk about waist circumference. The problem is, where do you do it? How do you do it? Not any of the people standardize it. Some people, it's extremely difficult to get the waist circumference. I want the panel, Dr. Vanita, Dr. Samit, where and how do you do it? I mean, we all know it is there, and breath held in expiration, this and that, but thoughts?
It'll require a bit of a practice revolution. And at Mass General Brigham, one of the weight management center, they have trained their staff, they do assess it. So, The specialists are getting the hang of it, but it will require a bit of a revolution. And then the question is, will it change management? I think it definitely affects risk estimation, but in terms of the practicalities of is it going to change the immediate management, that again is by the individual. So there's still a lot to do. It's not solved yet.
But Sundar, any questions? I don't see any more questions. I think we're running out of time, but I would like to
No, no,
thank
quick thing, if I may, just on the waist
Please, go ahead. We
circumference
still have a
and
couple of minutes you can use.
yeah, waist circumference, people normalize it for something. You see, I know the triglyceride HDL ratio is there. In China, it's the waist and some triglyceride. They kind of put some kind of a formula to do it. And waist hip ratio, I think, is gone away, I think. But, you see it, you know it. But many, many, many years ago, probably before Dr. Vanita, we thought about the waist to thigh ratio used to be around because the thigh is your biggest muscle mass over there. That's your insulin sensitive, and the waist is the biggest part there. And that something we did, we never published it. Waist to thigh ratio was a better predictor than waist to hip ratio at that time. I'm just putting it out there. I have no idea, first of all, where do you do it? How many centimeters above the knee and the patella? But just my own thoughts. But great questions, great presentations. I miss Samit, but Dr. Aroda, that was excellent. Yeah.
Thank you very much, both of you, for spending time and giving such excellent lectures. Very informative, very practical. And I think today we talked a lot about cardiovascular risk. It's probably been, a point where we all have dilemmas in treating and we don't know how to assess our patients very often and put them out of harm's way. Yes, Samit, please go ahead. Yes.
We participated in this IDEC coffee. We are very happy. Can you just tell me the results of the cricket score? We have missed it. I missed the match.
I wish I knew that, but as far as I know, I think they're winning. That's the only thing I can tell you. My son peeps in and say we are winning, so I know that much.
The ultimate unifier.
So three cheers for India. But yes, but I must say that we have more than 1,000 people who have logged in from 20 countries who have been listening to both these lectures. So that's a great achievement. I think the interest that these both of you have drawn, with your lectures to all across the globe. Thank you very much for being so nice to join this evening and give us such informative lectures. I can see the work that has gone behind putting all these slides together. Thank you very much, and I hope we'll continue to interact in future and have more lectures. So that's going to be a great feeling. Thank you, Sundar. Thank you, Guillermo. Thank you, Nita, for being part of this for the evening and contributing to the science. And it's really nice to have you with us. Nita, last comments from you.
Yeah, it's been an absolutely fantastic IDEC cafe, and I think it was the perfect comeback because we've had a little bit of a gap in between, and this has really kickstarted it fantastically well. And very very important issues have been addressed. Lot of food for thought, and it has been a wonderful experience. And I'm so happy that Guillermo and Sundar both could join us. It was really very nice. And thank you, Vanita, and thank you, Samit. Thank you so much.
Thank you.
Thank you. Enjoy the match now. The match. Bye. Thank you to all
Bye.
of you who've been part of the show.
Bye.
They've had incredible amount of interactions, and thank you all the viewers. Thank you,
Thank you. Bye bye.
Rahul.
Bye.
Yes, everybody. Thanks a lot. Bye. Bye.